आवाज़ तो इसकी आने
आवाज़ तो नहीं आ रही।
इसकी आवाज़ हमें नहीं आएगी। इसकी आवाज़ हमें नहीं आएगी। ये वीडियो चल रहा है, हमें तो नहीं आ रही।
नहीं नहीं, उससे नहीं, मतलब हमें स्पीकर पे आनी चाहिए।
नहीं नहीं, हमारे
हेडफोन पे।
स्पीकर पे आनी चाहिए ना। Hello. Good morning.
Good morning, Dr. Goel. From
Hello.
Lucknow.
Can you hear me?
Yes, yes. Can you hear us?
Yeah.
I'm Dr. Gambhir.
Yes, I can hear you, Doctor. This is Dr. Gambhir. Yeah. Welcome, sir. So
With me is Dr. Shiban. Just
we
let me
have a
introduce-
case today for you.
Let me introduce the
Okay.
chairpersons.
So who else is there in the panel?
Yeah, we have with me Dr. Shiban. We have with me Dr. Tharakan and Dr. Mark has just gone out. And we have a lot of panelists sitting across on the other side of the dais. So
Okay.
could you please introduce your case and then we move forward?
Yeah. So welcome everyone. So with me is Dr. Rupali, who's assistant professor with us, and we have our team here. So Rupali, can you just tell about the case?
Yeah, can we have the slide, please?
The-
Good
the
morning,
slide for
everyone.
Can we have the slide of the patient, please? Yeah.
Yeah, today we are doing a case of 60-year-old female. She is hypertensive and presented to us with a long-lasting effort angina, class 2 for past 8 years, with increase in her symptoms for past 6 months. And on a clinical examination, her BP and pulse rate was okay. ECG was normal, just a mild T-inversion AVL. And echo was of normal LV size with no RWMA, and ejection fraction was normal. So we took her for angiography, and what we get, it's like, you can just
Yeah,
guess.
so actually, so when we took her up for the angiogram, as you know, the LV is normal and she's had angina for some standing. So the LAD is occluded, the circumflex looks all right in this view. Next please, can we?
Forward.
Yeah, we should go forward. Okay, so the circumflex system is okay. We have a occluded LAD there. There is some ipsilateral filling of a diagonal through the circumflex system. Next. Just keep moving forward, please. Just keep moving. So it's a similar thing. Occluded LAD, and you have a small stump there. In fact, there's a tiny little diagonal coming out, and then it seems to be dwindling into total occlusion. Forward, please. Next, onwards. So that's the same thing. Can we see the right injection, please, now? So because right will show it filling through the collaterals. So that's the right injection, and we see there's a good collateral filling of the LAD, some to and fro flow. The RAO view also there shows some little calcium in the LAD area, and it is totally occluded. We get collateral filling. So that is what it was. So I thought when we do it, we'll probably do some simultaneous injections and get a better idea of the anatomy. So what do you, if someone has any thoughts on it, then we can talk about it. Otherwise, I'll show you the simultaneous injections. That's the LV that was done earlier. It's normal. So, and she has significant angina, so it needs to be opened certainly. So can we see today's angiogram that we have done, the simultaneous injections?
Next.
So basically, would you like to have some thoughts on the case, or should I go ahead? Just hold on.
Yeah, I think
Dr. Gambhir, sir, would you like to
yeah,
have
let
some
me
thoughts
just
on the panel?
summarize that
Or
for
we,
you. And basically, it is a CTO of LED and possibly a long CTO with good grade 3
Yeah, that's right.
collaterals from the right coronary artery.
Yeah,
And obviously, all the tips and
correct.
tricks of CTO has to be utilized here. And anybody from the panelists or any other person who is
Yes.
moderating or would like to make any comments as to whether we should use straight away a antegrade approach or should we use straight away retrograde approach? What would be your first approach? Dr. Shiban,
Yeah.
please.
Yeah,
Well,
I'm
actu-
Dr. Silvamani from
Actually,
Madurai.
this anatomy is very complex also for retrograde approach because there's a lot of tortuosity in the native vessel as well as in, I would say,
Can you
in
be a
the
little louder? I can't hear it very
collaterals.
well. Can the sound be increased?
Can you hear
I
me
cannot
now?
hear it very well. Huh.
You hear me now?
Yeah.
Yeah.
Yeah, that's
Yeah,
better.
okay.
That's better. That's better.
What I was saying, I
Yes,
mean,
correct.
my preferred approach in this lesion, I'll go for antegrade approach. Since retrograde, I think will be very
Yes.
complex
Yes.
because of tortuosity of the native vessels. I think what I can see from collaterals here, I think it would be very difficult to cross retrogradely. However, I mean, in my daily practice, I am attempting every time antegrade before doing any retrograde approach. So the same will be my strategy in this case.
Yeah.
Anybody
So-
from the other side of the
So
podium?
I agree on that. The thing is, we should probably, I think of antegrade approach first here, because especially because we have a leader, the LAD is there. So I thought I will do an antegrade approach only. But we have two guiding catheters. We have taken both the groins and we have guidings on both sides, so that in case there is an issue, you can think of a retrograde down the line, right? Because there is collaterals, septal collaterals, which are filling the LAD. So let us see. So we do a simultaneous injection. So what does a simultaneous injection? This is an epicaudal view. So you see the proximal LAD. Can we see the other ones? Next, please. So that's that's areocranial. So there is a gap about looks not that short either, but you do see that there is some track which might lead there. So the best bet here would be next, please. Next, please. That's the caudal injection. So that's for the onset of the collaterals. I did that. Next, please. And so that's where we are. So for the antegrade, actually now where I am, I have a microcatheter in place,
No.
which I put there
Dr.
using
Goel.
a regular workhorse wire.
Dr. Goel,
Yes,
just
yes.
before you move on with your
Yes.
discussion, just tell us what wire you're going to use as the first preferred wire, and
Yes,
Then-
so I'll just, so the plan for the antegrade is to have a microcatheter. To put the microcatheter in place, I use a regular wire, a regular workhorse wire, a New York Whisper or Sion. So I probably did it with a regular Whisper just to place it there. And once I am there, I will not put the Whisper beyond. I have pulled it out, and this is the wire which is inside is a XT. So the first wire that I use usually in situations like this, where you feel that the occlusion is leading towards the distal vessel, you have a XT, And the XT is a tapered tip wire, which is 010 at its tip, hydrophilic polymer coated. And I think it's a good wire for, especially if there are microchannels. And I think microchannels are there in several CTOs, which you don't see. Maybe in about 60% of the CTOs, you do have some microchannels. So only thing is now there is no push, and I'm just trying to rotate, and that's how I'll proceed. And my landmark will be the distal injection through the contralateral side. So can you just move it a little forward?
Okay, I think now we move on to Australia,
Yeah,
because
thank you.
Dr. Goel, you take your time
So if
to
someone
move
can,
forward. And in the meantime, we'll go to Australia and see what they are doing, and then we'll come back to you in another 5-10 minutes. Okay?
Okay.
Okay.
Okay. That's right.
We are back to you.
So can you show, are you with me?
One back.
Okay, can you show the 2 fluoro runs that I have done?
Back.
Back, please.
Back.
Back.
Yeah. Play.
Okay, I'll show you 2 live fluoros. So that's where the wire I was trying to, it has to be a very slow movement. It is progressing to some extent. And we need to keep cross-checking it. So it's moving forward a little. And is it over?
No. Yeah, it's done.
So that's how it's, okay. Next please.
Is that a whisper wire?
So that's the angio.
Is that a whisper?
So, no, this is a XT. Whisper will not do this job. No, this is XT. This is Fielder XT. XT, yes. I would, you see, XT can cross several occlusions. And as I told you, it's the best wire if there are microchannels. And microchannels are there in several CTOs, especially if you have a leader. You see, this is the good thing in this is that there was a leader. So there, XT, the only thing is XT has to be moved rather slowly, and only rotation, no pushing. Only rotation, no pushing, and you have to ensure the distal location with the contralateral injection all the time. And that's what I am doing. So no left injections, everything from the right injection. If you can show the hand, so very tiny rotations, and only rotation will probably take it forward, and no push.
Seems to be the good direction, the wire, but can you change projection so we can see
Can I see the left injection,
by
please?
contralateral
Sorry,
injection
right
whether it's
injection.
you?
Right injection. Looks okay.
Can do
Yeah,
LFT
seems
now.
okay. I would
okay.
change the
Ah.
projection at this point to see whether you are correctly in the through lumen.
Yeah, actually.
Seems to be, yeah.
Go to the LAO. It's going probably in the diagonal. Come on, left, right injection, please. It's going towards the diagonal.
Completely
Mhm. So you see that it's going towards the diagonals. Now to redirect it sometimes gets very difficult. Let me try it once, otherwise we'll do a balloon towards this. Left injection, sorry, right injection please. LAO पूरा है. You see, to redirect it is very difficult, this wire. It will go wherever it wants to go.
One of the contra of these guide
it's going
wires,
towards
I
the
mean
diagonal,
the
actually.
hydrophilic wires, is you don't have that much control in
come on.
torqueability, I mean, on the tip.
So it's going towards the diagonal. So one
So
way
it's
is
difficult
Toward the
to
diagonal and advance the microcatheter. So.
direct the wire.
just try to. trying to advance the microcatheter slightly. Where is the micro right now? No, right injection, right injection again. Okay, I am in a diagonal.
From here seems
Is it
to be
because I don't
in,
want to come
the
back
distal
too
part
much
seems to
also,
be
you
in
see.
this, in side branch.
Yes. I think let it be there.
Why not
Right
use
injection,
Gaia
please.
1 in this case? I mean, Gaia 1 will have, you will have much more torque, you can maybe direct better
No,
the
no,
wire.
because you see, actually the thing is, I have already crossed the occlusion.
Yes,
I am in the patent part of the distal vessel, right? Because
Yes.
that part is filling through collaterals, as you see. The only problem is this wire is just going in the diagonal. It is not, because to give a direction to this wire beyond the occlusion is very difficult. It is gripped inside the occlusion, and to redirect it into the
Exactly.
main vessel is difficult.
Yeah, I fully agree
So
with you.
one way is that I will let it go in the diagonal, move it forward, do a balloon dilatation, open the main track, and then get into the main LED. That is one way to do it.
I think before
So,
that,
but that diagonal then has to be big enough to take the balloon, but doesn't seem that big.
I think before that you can try to change wire. I mean, to change it, because
Can
it's
I-
very difficult to direct the wire because you don't have very poor torqueability, the tip of this wire. So I think if,
Yeah.
yeah,
Right injection.
I think I will also tend to agree that at this point, if you change it to Gaia 1 or Gaia, if that doesn't take the direction, then maybe Gaia 2. Because to direct this wire, it is difficult. I wouldn't say very difficult, but it's difficult.
Right
Gaia
injection
has
is
got a much better
on the second diagonal.
control over the tip.
The same diagonal, sir.
Same diagonal?
Same. forward
The
the
other
micro.
way is, what I'll do is I'll put a corsair here and put a parallel wire. Let this be where it is.
Crusade.
So I am, sorry, a crusade.
Crusade.
I am planning to put a crusade down.
you might advance the.
Okay, so this
2.5.
comes back.
Do you have a microcatheter there?
Yeah, I have pulled back the microcatheter. Can I have a crusade, please?
So,
You
but
can
trapping.
advance the microcatheter into
Crusade.
the lesion until the
We have to
Trapping?
trap.
You're trapping?
and change
Yeah.
the wire.
Well, yes, that is one, but it wasn't going as well. Let me see. if I
Any
can do
comment from
that.
the panel there?
Just hold on.
Dr. Goel, this is Dr. Ajit Menon. I would agree that
Fix it. Yes, sir.
with Dr. Sheban that you get in the microcatheter a little bit inside and then change the wire. Use a stiffer wire to try and torque it into the main vessel, because torquing this wire into the main vessel is going to be extremely difficult.
Mm,
So I think I would agree that the
right
change of a
injection.
wire at this
Right
point with the
injection, please.
microcatheter would be a good idea.
Ah, it
You see,
crossed.
probably my microcatheter is in the distal true lumen. If my micro is in the distal true lumen,
Yeah, that is good point
can
for
probably
microcatheter.
change the
Then
wire.
now you can change the wire.
let us do
and
that.
Try to.
Let's do that. Let's do that.
We want Gaia 1.
Should I try which wire?
Gaia 1 we can
Gaia
take.
1,
shift?
Gaia 1, or should I try
Regular whisper.
a regular Sion? Give me a Sion wire. Give me a Sion wire. Because if it is in, then
It will
Sion
cross.
should go. Because if,
Dr.
like,
Goel, we are going to, are shifting to Australia, then we will be coming back to see
yeah,
your results. Okay.
okay, right.
Hello.
left injection is- aha. Yes.
Yeah, we are with you.
Okay. Yeah, so I am here. So what happened was, can you show some of the last pictures?
Go
Just,
back.
In
Back.
fact, although I left the microcatheter at the
Back,
tip
back.
where I had probably crossed
Back,
the
back.
occlusion, but sometimes these wires get subintimal beyond, and especially I thought I'll use a regular wire because I'm already in the distal vessel.
Back.
So, but it wasn't going, so there was some subintimal passage. So then I planned for a parallel wire. So this is where the parallel wire is there. So, and this is actually the last one. With the parallel wire, now you see that my wire has gone into a diagonal properly. This is the second diagonal. Again, I am in diagonal, but this is the second diagonal. Are you convinced about it? Can you see the wire travel into a vessel which is being shown by the retrograde injection?
Yeah, we can see that.
So this is actually a Conquest Pro. What I did was that I changed over to a parallel wire. With parallel wire, I put a crusade down there, leaving the so-called dissected wire XT in its place where it is. And then on the crusade, I used first a Gaia 2. The Gaia 2 wasn't moving because the second wire has to be stiffer. So the Gaia 2 wasn't moving as well. So then I changed to Conquest Pro, and this is Conquest Pro, which you see going down into the vessel, and that vessel is diagonal. The LED is parallel to it. So still now that I have access, at least till the diagonal, I am using this access to do some balloon dilatations and increase the caliber of the proximal vessel. And then, so what will be left for me now will be to enter the main vessel from the division where that diagonal comes out. Are you getting what I am doing right now?
Yeah, I think
Because
totally
once
agree.
I go into the diagonal true lumen, so I have, you get it? So
Yeah.
I have access across the CTO, and at least I have opened till the towards the diagonal. And once I open it towards the diagonal, then the question is to enter the LED, which I can do most likely with another crusade catheter, again putting a crusade, and through the side branch, because this part was patent, and I think still it is patent, just that you are not able to direct the CTO wire into this. So a regular wire might work. So let's see what happens. So
I
that's
think
where
Dr.
I am
Goel-
right now.
Trapping it.
So what
Goel,
is it?
I'm trapping
I
it
think
with a crusade, sir.
can
So
you
now I
hear
want
us?
to put a crusade. Yeah.
I think I totally
Yes.
agree with you that in a situation like this,
Yes, I can.
where you are not able to get your wire into the main vessel at the exit point of the CTO, it is a good practice to do a balloon dilatation, a small possible balloon. And then, having done that, you have created a good
Yes,
channel
correct.
in the proximal segment and in the CTO. And then it may be easier for you to direct a wire either directly or using
Yes.
a crusade catheter, the second
Yeah.
wire into the main vessel.
Yes, that's the strategy. So I think that's what I'm going to do. And most likely I should be able to get
I'm
in
sure
there
you
now.
will succeed.
Because I have access across the CTO now. Okay?
Sure.
So
We have to
let's see, I'm
detrap it, sir.
putting the crusade. Are you trapped?
It's trapped, sir.
So with a trapping catheter, I'm putting the crusade
You
again.
have to detrap now.
Detrap, please. So now the crusade should move a little more forward, probably into the diagonal.
Diagonal.
Yeah, it's moving into the diagonal.
Regular de do.
Okay.
Sion.
Just a sec, let that wire be there. Okay. Show me the right injection. Because my proximal part should be just at that mouth. Then I will direct the wire there.
A
It
little
is a
back.
little beyond. So I'll pull the crusade back slightly. Test, please. Right injection. So maybe I'm here. Okay. So let's see. Give me a. Should I try a XT? Give
Sion.
me or should I try a Sion? Give me a
Sion,
Sion first.
So,
So let us try a Sion. If it has been opened, then maybe
Single.
the Sion could only travel. Well, I am right now taking only a Sion, hoping that because I have opened the main vessel, so I am in the true lumen because my distal vessel is in the true lumen. So a Sion might enter because the two will then be connected. So I'm just seeing whether a Sion would enter. Wire back. No, sorry.
It's there, sir. Already.
Interplater back. Okay, it's dead?
It's there.
Okay, it's dead. Okay. Right injection, please. Right injection, please. I think there is a part of occlusion there also. I think
Take
there's a
Gaia two?
part. Give me a Gaia
your
2.
CN wire very
Give me a
free.
Gaia 2. Because I just need. No, it's not as free. You see, probably there is some, certainly there is a plaque there with calcium. But I think we need to have some penetration there. So I'm taking
So
a Gaia
why don't
2
you take a conquest at this
for this
stage?
last part also. No, I don't want a conquest because I don't really want to make a very active penetration because I believe that I am already in the vessel. I hope you get what I'm
but the
saying.
exit point
I
sometimes
believe
may be
I'm
difficult.
because that is the only way I have gone into the diagonal. Unless I have entered the diagonal beyond this point also, which is a little unlikely. So, but anyhow, I have a Gaia 2 right now with me so that I can give some direction. And I can see the distal vessel right there. Can
Right
I
injection.
see the right injection, please?
No, there is the section here.
Just a sec.
Just at the exit point, you possibly have a dissection.
Might have, yeah.
ACTG.
Any comments from the moderators, please? You're free, please. Anybody would come out with any suggestion? Dr. Trihan?
Test, please.
Dr. Goel? Dr. Goel, can you hear me?
Yeah.
Acha. Actually, to me, I think the most important
Yes.
issue in this case is whether you have entered the true lumen proximal to the bifurcation or distal to the bifurcation. If you have entered proximal to the bifurcation and your primary crossing wire is in the diagonal,
that's
and also your
Ha.
crusader is in the diagonal, then I think it will be worthwhile to
So-
choose the softest possible wire and take the crusader down into the diagonal with a sharp curve, and as you are withdrawing your wire will slip into the diagonal. On the contrary, if you have entered
Actually,
distal to the
you are-
bifurcation, then you will be left only to puncture. In that event, you will have to use a wire which is suggested by Dr. Amir. So I think there are two extremes of wires to be
correct.
chosen, and they have to be decided on the basis whether you have entered
Yes.
proximal or distal. And that issue can be easily sorted out in case you have an IVUS with you. You can slip in an IVUS and find out whether you are in the true lumen, proximal to the bifurcation or distal to the bifurcation. That's my suggestion.
No, that's right. Because, can I just see the left injection?
So you have to backbleed. It's trapped. It's trapped.
Is it trapped?
No, it's not trapped. It's backbleed.
Sure. Left injection. Left injection, please. Okay, just a sec.
Dr. Goel?
Actually, the right
we have
injection,
left 2 or 3
Right
minutes. What about the option
you
to
see, I think maybe we have entered beyond the.
Beyond the
We have entered beyond. You see, I'll just comment on what Dr. Rehan said. But I feel probably we have entered beyond the bifurcation, and that is the reason I will need a penetrating wire. So Gaia 2 is not working, so I'll use a conquest. I will need a penetrating wire still because I have entered the distal true lumen in the diagonal beyond the bifurcation. So that is the answer. And so we need a conquest again. So let's see if I can. Can I
Dr.
have a
Goel,
curve on it?
what do you think about the option
So I
to take
have
the
to
risk,
use a
to
conquest.
predilate
Yeah.
the the segment you crossed in CTO. It was beyond the bifurcation, so I think you can take the risk to
Well, I have
pre-dilate.
already pre-dilated it with about 2 mm.
Which balloon you have used?
Well, I have used a 1.2 initially and then a 2. So it is, I have already pre-dilated it slightly.
But you're still not
But
seeing
you know, the way
direct flow, I mean.
the wire is gone, it seems to me that it has gone, I have really entered the true lumen in the diagonal distally beyond the bifurcation. So that is the problem. So I have to penetrate towards the main vessel. So
Dr. Goel,
that's
we have
what
got
I'll
strict
just
instructions that
I'm
the
trying to
time
do
is
if I
finished
can
for
do it in
the
time, it's
satellite.
okay.
So you'll have to immediately de-link it. And
Okay, so but
you
yeah,
please
that's
continue
fine.
with conquest. And I
Okay,
am sure
but
you'll be
I
able to
think
cross it.
that's the last part, and I think I should be able to do it.
Yeah, I think you will be able to cross it, and I'm sure with your expertise
Yeah.
in
Thank
CTO.
you. Thank you.
Thank you
Thank
very
you.
much for the wonderful presentation, and hope to see you this case
Yeah.
when you complete it. Show us the
Thank you.
the completed case whenever you come back to the conference.
Okay. Right. Certainly. Thanks.
With that, I